K.V. Krishnadas Oration, which will be delivered by Professor Mammen Chandy. And the third, which follows, will be a panel discussion on bone marrow transplantation. Professor K.V. Krishnadas, or K.V. Kesar, as he is fondly called in the circle, the academic circle, is one of the greatest academicians and clinicians ever produced by this alma mater. He had the opportunity to serve this institution for long with distinction and dedication. His clinical skills are extraordinary, and his practical wisdom is unparalleled. He has inspired generations of students in this campus and continue to do so, inspire the students through his textbooks of clinical medicine and clinical methodology. And I'm privileged to be one of his students, and I know many among also would be. So when Sir started his foundation with some academic targets, there are many things which are common with the Alumni Association, and we identified those target areas, and we thought it's more convenient to have a synergy and working together. We have identified 3 such areas to start with, which I'll spell out to you. The one is, in fact, the hematology, and you should be knowing that Sir is the first clinical hematologist in the state. So, to enhance and expand the knowledge in hematology, which is fast expanding, through deliberations, discussions, orations, and then improving the training in hematology, and also promoting the research in hematology is one of the prime areas. And in fact, this academic event is the first of the same process. And we know that the state is weak in this area, in hematology, and the Trivandrum also. Another concept we are trying to develop, in fact, is the concept of the School of Tropical Medicine. You know, with the emergence of Nipah, the amoebic meningitis, etc., there is a need to have a closer look into the tropical medicine, the neglected tropical diseases, etc. And for the formation of a School of Tropical Medicine of national and international focus of attention is another area of interest for these things together. And maybe another one, in fact, is the expanding the editorial board of Sir's publications to have more professional approach, to bring more popularity and acceptance world over is another thing. So I would like to request all of you across the world to participate with your suggestions, with your academic contributions and supports to all these areas where we are actually trying to work together. Now coming to my duty of welcoming you all. Our chief guest is Padmashri Professor Mammen Chandy, sir, from Vellore. He's a tall figure, he's a doyen in the bone marrow transplantation, and the country has actually honored him with the Padma Award. So we are very happy and privileged to have you with us. You have agreed gracefully to our invitation, being here to inaugurate the session and also deliver the oration. So with a lot of warmth, love, and affection, may I welcome you to the gathering. I also welcome Madam Chandy, who has kindly accompanied him. And all the other dignitaries, they really belong to the organization team. And I'll be just naming them to save time. Welcome our President, Dr. John Panikar, He is the king, the kingmaker, and the kingpin of the association, the alumni. And our Vice Chancellor, Honorable Vice Chancellor, Dr. Mohan Kundumal, will be offering the academic salute to our legend, Krishnadas sir. Welcome you, sir. Dr. Soumya Swaminathan needs no introduction. She was the former director of ICMR and later this chief scientist of WHO. So, madam, I welcome you. We know you are interested in One Health. We are also interested in that. And probably we can have debate on these things and we will have probably another area to work together. And we have, our DME is not here, probably he has got the official duty. But our DME has agreed to come, and our principal, Dr. Jabbar, is there. Both of these people, they have assumed the office recently. First of all, our felicitations and congratulations to you, and our supports for all your projects and activities which will be good for the institution and for the public in general. Dr. Narayan is the secretary of the foundation. Thank you for joining hands with us. He's the son of KVK, and let it be the beginning of a long journey. And I would like to welcome all the districts for the academic activities which are going to follow. I'm not going to name all these people. I also welcome the office bearers of Alumni Association, VC Mathuri Academy, and KVK Foundation. This is a very rare and distinguished moment where I find more expertise and experience among the audience. Well, I'm very much happy with the and enthusiastic of your distinguished presence. Again, I'm not naming each and every person, but we are privileged to have you here, and I would like to individually welcome you all to this function. I would like to welcome the online participants across the globe. That is our strength, that is the strength of the alumni. Active members across the globe in US, UK, Canada, Middle East, and even South Africa. I welcome you all. And I request, appeal to you that you may actively participate during the panel discussion. I acknowledge the gracious presence of KVK sir here, with madam. In fact, he's the chief host. I'm welcoming all of you really on his behalf. And sir, we are blessed with your graceful presence. And I welcome you all once again to this solemn function. Thank you.
Thank you. My beloved and respected teacher, Krishnadas sir, madam, Chief Guest, Dr. Mammen Chandy, and Dr. Soumya Swaminathan, our Vice Chancellor, Dr. Mohan Kundumal, Principal, Dr. Jabba, our Dr. Matthew Roy, Academy Chairman and the coordinator for this meeting, Dr. Vinay Kumar, Dr. Narayanan, our Secretary, Dr. Kavita Ravi, my dear teachers, friends, colleagues, and family members of Krishna sir. Actually, we consider this as a great privilege and honor that the Alumni Association has been asked to organize this meeting. In the name of one of the greatest teachers of medical teacher, probably not only in Kerala, whole of India. Such students, I am sure, see, after seeing this online, thousands of students whom Sir has taught are there in USA, UK. Dr. Anup Iqbal from USA, he has just joined this meeting physically. So, and my own many teachers, all the teachers, actually, I was fortunate that I was his student for the third year and final year. I was in his unit. And there only I learned basics of medicine. Particularly, I still remember, we were all asked to take the blood and urine, motion, everything to the lab and do ourselves. Still we know how to do all these tests. So that was in 73, I feel. And I don't want to prolong my speech, but the thing is, so many are there to speak also, and then we have a lot of very good academic program is there. But the thing is, Sir was the synonym of hard work. Everybody knows that. Integrity and clinical acumen. And we are all fortunate that we were all students of Toronto Medical College. And Sir, even actually the Alumni Association we started in only 2005. In the last 20 years, Sir was one of the greatest inspiration for the Alumni Association. He used to call me, Panika, what is the next program and all. Till recently, for every function, Sir was there in the seat and probably in the podium also. So that was his, and actually, this is, don't consider this as just an academic. This is, we all consider this as a tribute to the greatest teacher of, medical teacher of Kerala. And we bow before you, sir, and we are extremely thankful, and thank you very much. Now I request, what? Yeah, there will be, is Dr. Mohan Kumannamal, Vice Chancellor, to give the tribute, and followed by there will be a video clip, and then there will be the inauguration.
Good evening. എല്ലാവർക്കും നമസ്കാരം. ഏറ്റവും വന്യനായ നമ്മുടെ ഗുരുനാഥൻ കെ വി കൃഷ്ണദാസ് സർ, ഈ യോഗത്തിൻ്റെ അധ്യക്ഷത വഹിക്കുന്ന ഡോക്ടർ സി ജോൺ പണിക്കർ, ഇന്നത്തെ മുഖ്യ അതിഥി പ്രൊഫസർ മാമൻ ചാണ്ടി, കീനോട്ട് അഡ്രസ് നിർവഹിക്കുന്ന ഏറ്റവും ബഹുമാന്യയായ ഡോക്ടർ സൗമ്യ സ്വാമിനാഥൻ, പ്രിൻസിപ്പൽ ഡോക്ടർ പി കെ ജബ്ബാർ, നന്ദി പറയുന്ന കൃഷ്ണദാസ് സാറിൻ്റെ പ്രിയപ്പെട്ട മകൻ ഡോക്ടർ നാരായണൻ, ഇവിടെ സന്നിഹിതരായ ഏറ്റവും ബഹുമാന്യരെ, പ്രിയമുള്ളവരെ. ഞാൻ ഈ സ്റ്റേജിൽ എത്രയോ പ്രാവശ്യം നിന്നിട്ടുണ്ട്. വിദ്യാർത്ഥിയായി, അധ്യാപകനായി, സമരം ചെയ്യുന്നയാളായി. പക്ഷേ എൻ്റെ ഏറ്റവും ധന്യമായ ഒരു നിമിഷം ഇതാണ് എന്നാണ് എൻ്റെ വിചാരം. കൃഷ്ണദാസ് സാറിനെ ഒന്ന് പരിചയപ്പെടുത്താൻ കഴിയുക എന്നുള്ളത് എൻ്റെ ഏറ്റവും ധന്യമായ നിമിഷമായി ഞാൻ കണക്കാക്കുകയാണ്. 1932 മെയ് ദിനത്തിലാണ് സാറ് ജനിക്കുന്നത്. മെയ് 1, അപ്പോൾ മെയ് ദിനമാണ്. മെയ് ദിനത്തിലാണ് സാറ് ജനിക്കുന്നത്. കുട്ടനാട്ടിലെ മങ്കൊമ്പ് ഗ്രാമത്തിൽ, കൊട്ടാരത്തിൽ മഠത്തിലാണ്. കൊട്ടാരത്തിൽ രാജാക്കന്മാർ മാത്രമേ ജനിക്കുകയുള്ളൂ. വൈദ്യശാസ്ത്രത്തിൻ്റെ രാജാവ് കൊട്ടാരത്ത് മഠത്തിലാണ് ജനിച്ചത്. യാദൃച്ഛികമല്ല, ചില കാര്യങ്ങൾ നമ്മൾ കാണണം. 1950 യൂണിവേഴ്സിറ്റി കോളേജിൽ നിന്ന് BSc കെമിസ്ട്രി അദ്ദേഹം പാസ്സാവുമ്പോൾ കേരളത്തിൽ മെഡിക്കൽ കോളേജില്ലായിരുന്നു. ഒരുപക്ഷെ കൃഷ്ണദാസ് സാറിന് ജോയിൻ ചെയ്യാൻ കൂടി വേണ്ടിയിട്ടായിരിക്കണം 1951 ഈ മെഡിക്കൽ കോളേജ് തുടങ്ങിയത്. ഈ മെഡിക്കൽ കോളേജിൽ ആദ്യത്തെ സ്റ്റുഡൻ്റ് എന്ന് മാത്രമല്ല, ഏറ്റവും മികച്ച സ്റ്റുഡൻറ്റും കൂടിയായിരുന്നു എന്നുള്ളതാണ്. 5 ഗോൾഡ് മെഡൽ, ബെസ്റ്റ് ഔട്ട് ഗോയിങ് സ്റ്റുഡൻറ്റിനുള്ള ശ്രീപത്മനാഭസ്വാമി മെഡൽ, ഇതൊക്കെ നേടിയാണ് കൃഷ്ണദാസ് സാർ ഈ ക്യാമ്പസിൽ നിന്ന് പുറത്തിറങ്ങാത്തത്. അദ്ദേഹം ഇവിടെ തന്നെ പതോളജി അധ്യാപകനായിട്ട് ചേരുകയായിരുന്നു. അടുത്ത വർഷം അദ്ദേഹം 57 മെഡിസിൻ അധ്യാപകനായിട്ട് ചേരുകയായിരുന്നു. 87 വരെ ഈ മെഡിക്കൽ കോളേജിലെ മെഡിസിൻ അധ്യാപകനായിരുന്നു. ഡയറക്ടർ എന്ന നിലയിൽ ഗവൺമെൻറ് വിരമിക്കാൻ പറയുന്നത് വരെ അദ്ദേഹം ഒരുപാട് പുസ്തകങ്ങൾ എഴുതിയിട്ടുണ്ട്. അതിൽ ഒരുപാട് ലേഖനങ്ങൾ എഴുതിയിട്ടുണ്ട്. ടെക്സ്റ്റ് ബുക്ക് ഓഫ് മെഡിസിൻ ഇപ്പോൾ 6ാമത്തെ എഡിഷനാണ്. ക്ലിനിക്കൽ മെഡിസിൻ അതും 6ാമത്തെ എഡിഷനാണ്. APIയുടെ എല്ലാ എഡിഷനിലും, API ടെക്സ്റ്റ് ബുക്ക് ഓഫ് മെഡിസിനിൽ എല്ലാ എഡിഷനിലും കൃഷ്ണദാസ് സാറിൻ്റെ പ്രസൻസ് നമുക്ക് കാണാൻ കഴിയും. അദ്ദേഹം ഹെമറ്റോളജി ഡിപ്പാർട്ട്മെൻറ്റ് തുടങ്ങിയിട്ടുണ്ട്. പക്ഷെ അദ്ദേഹത്തിൻ്റെ ഏറ്റവും വലിയ കോൺട്രിബ്യൂഷൻ ഇതൊന്നുമല്ല. ഏറ്റവും വലിയ കോൺട്രിബ്യൂഷൻ ആയിരക്കണക്കിന് മികവാർന്ന ഡോക്ടർമാരെ ഈ നാടിന് നൽകി എന്നുള്ളതാണ്. ദാറ്റ് ഈസ് ദ ഗ്രേറ്റസ്റ്റ് കോൺട്രിബ്യൂഷൻ. ആ കോൺട്രിബ്യൂഷനാണ് എൻ്റെ മുമ്പിൽ ഇരിക്കുന്നത്. നമ്മളെല്ലാവരും അതാണ്. അദ്ദേഹം നല്ലൊരു കർഷകനായിരുന്നു എന്നുള്ളത് എത്ര പേർക്ക് അറിയാമോ എന്നറിയില്ല. അദ്ദേഹം ഇപ്പോഴും കർഷകനായിട്ട് തുടരുന്നു എന്നുള്ള കാര്യം ഇപ്പം മകൻ പറഞ്ഞപ്പോഴാണ്. വളരെ വലിയൊരു കർഷകനായിട്ട് തുടരുന്നു എന്നുള്ളതാണ് ഞാനിപ്പോൾ മനസ്സിലാക്കുന്നത്. അതുകൂടാതെ വേദങ്ങളിലും സംസ്കൃതത്തിലും മഹാപണ്ഡിതനും കൂടിയാണ് എന്ന് എത്ര പേർക്കറിയാമെന്ന് എനിക്കറിയില്ല. തീർച്ചയായിട്ടും ഒക്കെ നമ്മളെ സംബന്ധിച്ചിടത്തോളം വലിയ വലിയ അഭിമാനം തോന്നുന്ന കാര്യമാണ്. എന്നെ സംബന്ധിച്ചിടത്തോളം അതിലും മുകളിൽ മറ്റൊരു കാര്യം കൂടിയുണ്ട്. ഞാൻ ഈ കോളേജിൽ പഠിക്കുന്ന കാലത്ത് ഒരു ചെറുകിട വിദ്യാർത്ഥി നേതാവായിരുന്നു, സമരം നടത്തുന്ന ആളായിരുന്നു, കോളേജ് യൂണിയൻ ചെയർമാനായിരുന്നു, സ്വാഭാവികമായിട്ടും ക്ലാസ്സുകൾ അറ്റൻഡ് ചെയ്യാത്ത ആളായിരുന്നു. അങ്ങനെ ഇരിക്കെ ഒരു ദിവസം വാർഡിൽ വെച്ച് സാർ എന്നെ കണ്ടു. എന്നിട്ട് പറഞ്ഞു, മിസ്റ്റർ ചെയർമാൻ, യു ക്യാൻ ഓണർ അസ് ബൈ അറ്റൻഡിങ് ദ ക്ലാസ്സസ് ആൾസോ. സത്യത്തിൽ ഞാൻ ആ നിമിഷം ഭൂമിയുടെ അടിയിലോട്ട് താണുപോയി. പക്ഷേ അതിനുശേഷം ഞാനൊരു ക്ലാസ്സും മിസ് ചെയ്തിട്ടില്ല. എനിക്ക് MBBS കിട്ടാനുള്ള കാരണവും അത് കഴിഞ്ഞ് പോസ്റ്റ് ഗ്രാജുവേഷൻ കിട്ടാനുള്ള കാരണവും ഇപ്പോൾ VC ആയിട്ട് ഈ വേഷമിട്ട് നിൽക്കാനുള്ള കാരണവും സാറിൻ്റെ ഒരു കമൻറ്റ് മാത്രമാണ്. സോ എന്നെ സംബന്ധിച്ചിടത്തോളം സാറിനെ പരിചയപ്പെടുത്താൻ കഴിയുക എന്നുള്ളത് എൻ്റെ ഏറ്റവും ധന്യമായ ഒരു കടമയാണ്, ചുമതലയാണ്. സാറിൻ്റെ അസാധാരണമായ ഓർമ്മശക്തി ഞാൻ കണ്ടിട്ടുണ്ട്. ഒരുപാട് വർഷങ്ങൾക്ക് ശേഷം കൽപ്പറ്റയിൽ IMAയുടെ ഒരു കോൺഫറൻസിൽ വെച്ച് എന്നെ അടുത്തുനിന്ന്, ഡോക്ടർ മോഹനൻ വേർ ആർ യു, എൻ്റെ പേര് എൻ്റെ ക്ലാസ്മേറ്റ്സ് പോലും മറന്നിട്ടുള്ള കാലത്ത്, സ്വന്തം മക്കളുടെ പേര് അച്ഛന്മാർ പോലും മറക്കുന്ന കാലത്ത്, എത്രയോ വർഷങ്ങൾക്ക് ശേഷം ഡോക്ടർ മോഹനൻ വേർ ആർ യു എന്ന് ചോദിക്കുമ്പോൾ ഞാൻ തീർച്ചയായിട്ടും ആ പാദങ്ങൾ നമസ്കരിക്കുകയാണ്. എനിക്ക് കൃഷ്ണദാസ് സാറിൻ്റെ ചില ഭാഗങ്ങൾ പരിചയപ്പെടുത്താൻ കഴിഞ്ഞത് എൻ്റെ ഭാഗ്യം എന്ന് പറഞ്ഞുകൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ അവസാനിപ്പിക്കുന്നു. നന്ദി, നമസ്കാരം.
Now there is a short clip of 2 minutes regarding the life of Krishnadas sir.
Dr. K.V. Krishnadas, a life dedicated to medicine, teaching and humanity. Krishnadas was inspired early in life by his father's words. Doctoring is the only profession which can be of use to all persons at all times till the last breath. And that philosophy became the heartbeat of his long and illustrious career. A graduate in chemistry from University College Trivandrum, Krishnadas soon joined the first MBBS batch of the newly established Medical College Trivandrum in 1951. He passed out with flying colours, winning 5 gold medals including the prestigious Sri Padmarabhaswamy Medal for the Best Outgoing Student of 1956. He pursued advanced studies abroad, earning his DTM and H from the University of Edinburgh and becoming a member of the Royal College of Physicians in 1960 and later honoured as FRCP in 1978. He completed a 6-month research fellowship in hematology at the University of Edinburgh under the academic supervision of Dr. Ronald Girdwood and Dr. Derek Dunlop. His official career began at Medical College Hospital, Trivandrum, first as a tutor in pathology, then medicine, and rising to become professor of medicine and eventually director of medicine, a post that he held until retirement in 1987. During his tenure as a tutor in pathology at the Medical College Trivandrum, he had the opportunity to work with Professor Girendo, a distinguished expert in hematology. Among his many pioneering contributions was the establishment of the hematology section in 1982, a milestone for Kerala's medical education. Dr. Krishnadas was more than a clinician and teacher. He was a leader in numerous medical societies. He was the president of the Indian Medical Association Trivandrum from 1980 to 83, the president of the Indian Society of Hematology and Blood Transfusion from 1977 to 79. He was also the president of the API Kerala chapter as well as the organizing secretary of major national conferences including the API meet in 1980. His role in national institutions were equally impactful. He was a governing body member of the AIMS, council member of the National Academy of Medical Sciences, and examiner and mentor across India's top universities. With over 200 scientific publications, primarily in hematology and internal medicine, Dr. Krishnadas was a prolific researcher. His areas of interest spanned leukemia, lymphoma, nutritional anemia, coagulation disorders, and tropical medicine. Dr. Krishnadas has also published the Textbook of Medicine, 1st to 6th editions, the Textbook of Clinical Medicine, the 1st to 5th editions. He has also been a contributor to all editions of the API Textbook of Medicine and several hematology monographs. Dr. K.V. Krishnadas's journey is a shining example of dedication to medicine, education, ethics, and humanity. His legacy continues to inspire generations of doctors, students, and all those who had the privilege to know him. In 2005, the Kerala chapter of the API honored him with the Lifetime Achievement Award. But perhaps his true reward was the joy of teaching, of healing and learning, a journey that he describes as, "I enjoyed every bit of learning, teaching and publishing, especially the mutual interaction with patients, students, colleagues and the public. Hard work pays great dividends. The more you give out than you receive, the happier you become. And honesty will always find its way to success."
Friends, I am happy to see my lifelong ambition coming to fruition. Thank you for being a part of this journey. My best wishes and blessings.
Dr. K.V. Krishnadas, a healer, a teacher, a scholar, and above all, a noble soul whose life reminds us that medicine is not just a science, it is a service.
Award, the Legend of Trivandrum Medical College Award right now. I request all of them, our principal, including our principal, in the stage to come to the near the sir and present this award with me. Thank you. Let me invite Dr. Mammen Chandy to inaugurate the CME. Thank you. We'll, after lighting the lamp, probably we can. Please go.
Dr. K.V. Krishnadas, sir, Madam, dignitaries on the dais, members of the Alumni Association of Trivandrum Medical College, I have great pleasure today in inaugurating the Krishnadas and Kamalam Foundation for Hematology, and I'm sure that this will advance the field in this state, in India, and other parts of this world because of the students who train. Many years ago, I was asked to speak at an API meeting. And as all of you know, API is a chanda. Thousands of people. And in the pandal, before us was the cardiology session. And Dr. Advani and myself were speaking in the hematology session. And after the last cardiologist had finished, the hall emptied out. And there were about 3-4 people sitting and listening to us. So I was talking to somebody before the meeting, and he said, nowadays that is not true. Hematology is one of the prized specialties which people want to listen to because they know their everyday practice is dependent on an understanding of blood diseases. When a child comes with thrombocytopenia and is bleeding, you want to know immediately what to do, whether it's a pediatrician, whether it's a physician, or even a geriatrician. So I am so happy that Dr. Krishnadas, I have seen him in many hematology national meetings, and he always furthers the cause of hematology. So I'm sure that today, with the start of this foundation, there will be a further impetus for the development of this specialty. When I trained and came back from Australia, there was no DM course in India. And the pathologist would see the material and the clinician would treat, and never the twain would meet. So the discipline of clinical hematology is where a physician understands what happens in the lab and translates that to the care of patients with blood diseases. Thank you very much.
May I request Dr. Soumya Saminathan to felicitate. Thank you. The keynote address, sorry.
Distinguished dignitaries and alumni, and I think students and admirers of Professor K.V. Krishnadas, and also family members. I see quite a large number of family members here. So he's also my uncle, and I remember when I was just finishing my internship and starting my residency program, and in those days he was a very dreaded examiner who would come to Delhi from time to time, and the news would spread even before he came that Dr. Krishnadas is coming as examiner, and students would be very fearful because of the strict, not only because he was so good and he examined so well, but his integrity was well known. And everybody knew that you could not influence his judgment, and he would go only by how the student performed. So in those days, he used to also ask me why I'm sleeping so much in the night. And I used to tell him I've come back after 36 hours of night duty and all that. He said, no, you have to get up anyway at 5, first run 10 miles, then come back. Then you have to read the Lancet every morning. And I remember going for a jog with him and not being able to keep up, even though I was 21 or 22 at that time. So I think many of the speakers have talked about his qualities, not only as an excellent medical teacher, who of course was a pioneer in the field as well. And till a couple of years ago, he was editing his textbook. I don't know if he's still editing it now. And even during COVID and after that, when everything went online, he could not stay without seeing his patients. So he was seeing them online and also sending me articles. I was in the WHO then, and he would often write to me emails, sending me articles which he had read, which were interesting, and also, feeling happy that I was performing a role at that time that he felt was useful. So I think the qualities that we celebrate today and through the foundation, I think for the future, and I congratulate Dr. Narayanan and Kumar and the family members for having set up this foundation, and get the blessings of Dr. Krishnadas and Kamalam Chitti, for the first meeting, to think about the future frontiers of medicine. This technology is advancing very rapidly, both in hematology, in oncology, and in other fields. But we have to remember that technology is not the only thing. It has to be combined with attention to equity, to access, and to compassion in care. And I think that is what he also embodied, that compassionate and humane approach to patients was always combined with the latest knowledge on the scientific advances. So I hope that today, and we have a very, very eminent, also pioneering hematologist and the father of bone marrow transplantation in India, Professor Mammen Chandy, to give the first oration, followed by a panel discussion. And I'm looking forward to the evening, but also very hopeful that this foundation will create the next generation of Dr. Krishnadases. We need people with those qualities and values in medical teaching, in medical research, for innovation. We need it among scientists and policy makers so that we can keep on improving access to quality healthcare in India. So thank you very much for giving me the opportunity to be here this evening, and I'm looking forward to the proceedings. And many thanks to the Alumni Association of the Trivandrum Medical College.
Thank you, Madam. I request our Principal, Dr. Jabbar, to felicitate.
Good evening, everyone. First of all, I want to convey the greetings from Director of Medical Education. He is very busy with the Minister's office. And now I will start my felicitation. The great teachers in the dais, and my teachers in the crowd, and probably one of the most precious moment for me to address this audience. You know why? Because the doyens are sitting here. Of course, see, the equally or strongly, probably better than the doyens sitting in the dais. My teachers are sitting here. K.P. Paulos are sitting here. My great teacher Kashi sir is sitting here. Matthew Thomas sir, and lot of doyens in the field of medicine is gathering here to felicitate. My dear friends, for me, as a principal of Trivandrum Medical College, I welcome all of you. And alumni, of course, any problem for me, even the silliest problem for me, I used to call Dr. John Panikar and Kavita also. So they are readily help me for a lot, and they are always with us for the progress of the institution. On behalf of my institution and our own institution, I thank all the alumni members for giving or for extending the help to improve the institution here. And I don't want to say anything about the caliber and the subject we are going to have today. And may I stop here and best wishes, and may God bless you. I'm signing off. Thank you very much.
Thank you. And now we'll go for the vote of thanks by Dr. Nar.
Thank you. Good evening to all of you. I don't want to stand for too long between you and the forthcoming lecture by Professor Mammen Chandy, so I will make it short and sweet. It's my proud privilege to deliver the vote of thanks on this momentous occasion, the official launch of the Krishnadas and Kamalam Foundation. On behalf of the entire team behind this initiative, I extend our heartfelt gratitude to all of you for being here, both physically and virtually, to witness and support the beginning of a journey that is deeply rooted in service, in empowerment, and in transformation. First and foremost, I extend my sincere thanks to our chief guest, Professor Mammen Chandy, for taking the time. Please put your hands together. From his demanding schedule to grace this occasion. Your inspiring words, sir, in this short intervention that you had now, and looking forward to the forthcoming lecture, has not only added immense value to our launch, but has also encouraged us to strive with purpose and passion. So as a token of our appreciation from the Krishnadas and Kamalam Foundation, I request Dr. Soumya Swaminathan to hand over a plaque to commemorate this event to Dr. Mammen Chandy. Please put your hands together, friends. It's a great occasion for all of us. I would like to thank Dr. Kunnumel, the Vice Chancellor, for his excellent exposition of the life of Dr. Krishnadas. The head of the Alumni Association, Dr. Panikar. Medical College Principal, Dr. Jabbar. The DME who couldn't come because of some exigency, Dr. Vishwanathan. Dr. Soumya Swaminathan for her encouraging words, and for all of them for the support in organizing this event. We are extremely grateful to our distinguished guests, dignitaries, and supporters, both on the dais and off the dais, whose presence here today reflects a shared commitment to the vision we have for the Krishnadas and Kamalam Foundation. Your encouragement reaffirms our belief that science, or rather science-based, evidence-based healthcare, combined with compassion and community participation, can truly make a difference. A heartfelt thanks to all my fellow trustees on the Krishnadas and Kamalam Foundation, Professor Matthew Thomas, who is sitting in the first row here, Professor Kashi Vishweshwaran, Dr. Vinay Kumar, Dr. Soumya Swaminathan, whose vision, dedication, and unstinting engagement have made this foundation a reality. Your leadership will be the guiding light as we begin our work with the medical fraternity and the community. Lastly, to each and every one of you present here today, a big thank you. Your presence is not only a gesture of goodwill, but also a sign of hope that together we can build something impactful. I recall an old adage, it's not the mighty sails that move the ship, but the unseen wind. You, my dear friends, your moral and material support is that unseen wind. Let it blow strongly and consistently so that we can cross the mighty oceans, negotiate the narrow straits, the risky fjords together so that each we can reach our coveted destinations together. Like my friend Dr. Vinay Kumar listed, we have listed a number of initiatives. I would like your suggestions and your participation and your support in making sure that we reach the right destinations. As we step forward from this day, the Krishnadas and Kamalam Foundation is committed to serving with integrity, inclusivity, and innovation, uplifting lives one step at a time. With gratitude in our hearts and a clear vision in our minds, we look forward to your continued support in the days to come, in all our endeavors. Thank you, and let us move forward together.
I think with this probably we can move to the oration part. Thank you. And hand over to Dr. Vinay Kumar. Thank you.
May I call upon the following chairpersons to chair the oration. Professor Kashi Vishweshwaran, Professor Matthew Thomas, Professor K.P. Paulos, and Professor Kavita. Please initiate the proceedings.
Professor Mammen Chandy. Professor Mammen Chandy, Professor Krishnadas, Madam, my teachers, and my dear friends. This oration is in the name of Dr. Krishnadas, and the speaker is Dr. Mammen Chandy. I was supposed to talk about Dr. Krishnadas a bit, but all the speakers have already explained the complete life history of Krishnadas. I would just start with only one anecdote. I joined as for MD Medicine, and my first posting was with Professor Krishnadas' unit, and I learned medicine only from that time. You go around with him, and every time you are with him, and he will hold you by your upper hand and shake you one little bit and say, look, you have missed this finding. I might have missed a coelonychia. Or he will take you to the microscope and ask you to identify a cell, and then you say you are not able to do it. Then he would say, describe the cell clearly. What is the size? What is its relation to the RBC? Is it nucleated? Is it non-nucleated? And like that, he made me identify, by questioning me itself, my own words. He made me identify a megaloblast, which is a very rare cell that we see here. So we have learned a lot. He has been my mentor. He has been my guide. And various books that he has edited, he has involved me also. And that has given me a stimulus to write my own, editing my own books. So with all this, with all respect to Dr. Krishnadas, I stand here. Namaste.
Professor Krishnadas sir, Amma, Krishnadas sir, as all of you have unitedly said, he was my teacher, mentor, my guiding light who has shaped my life, thoughts and dreams. Beloved family members of sir, esteemed chairpersons, fellow alumni association committee members, and all the distinguished guests and doctors who have gathered here, warm greetings to you. It is indeed our privilege and honor to host Padmashri Professor Mammen Chandy for the inaugural oration under the prestigious banner of Krishnadas Kamalam Foundation Trust, organized by the Alumni Association, Trivandrum Medical College. This marks a significant milestone in our academic journey, and we could not have chosen a more distinguished speaker for this momentous occasion. I have had the privilege of knowing Professor Mammen Chandy for over at least 4 decades, and he remains not just as a colleague but a dear and cherished friend. Today I stand before you to introduce a true pioneer in Indian medicine, a visionary who has transformed the landscape of hematology in our country. Professor Mammen Chandy's contribution to medical science are truly extraordinary. He established India's first clinical hematology unit at Christian Medical College, Vellore, a groundbreaking achievement that laid the foundation of modern hematological care in India. More remarkably, he performed India's first bone marrow transplantation for thalassemia, opening new horizons of hope and for countless patients and their families. Under his leadership, the hematology department of CMC Vellore evolved into a world-class center of excellence, setting benchmarks that continue to inspire medical institutions across the globe. His prolific research career is marked by numerous publications and his role as principal investigator in several landmark clinical trials that have advanced our understanding of hematological disorders. Even after his retirement from CMC, Professor Chandy's dedication to medicine remains unwavering. He joined the Tata Memorial Center, Calcutta, where he replicated his earlier success, elevating their hematological program to match the standards he had established at Vellore. Currently, he continues to serve patients with the same passion and expertise as a hematology consultant at Naruma Hospital, Vellore. The Government of India recognized his exceptional contributions to medicine by honoring him with the Padmashri, one of the nation's highest civilian awards. This recognition is not just a personal achievement, but a testament of how one individual's dedication can transform an entire field of medicine and touch countless lives. Professor Mammen Chandy's journey exemplifies the perfect blend of clinical excellence, research acumen, and compassionate patient care. His work has not only saved lives, but has also trained generations of hematologists who continue to carry forward his legacy across India and beyond. Ladies and gentlemen, it gives me intense pleasure to present to you Padmashri Professor Mammen Chandy, who will enlighten us today on the basics of bone marrow transplantation. May his continued pursuit and excellence in hematology inspire us all and continue to bring hope and healing to many more patients in the near future. Professor Mammen Chandy, the floor is yours. I also like to present the medallion.
Thanks. Matthew, thank you very much for those very kind words. I have known Matthew for many years, and it's a pleasure to discuss cases with him. Professor K.V. Krishnadas, Madam Kamalam, I would like to thank you for this honor. And I'd like to thank Narayan because he's the one who has been coordinating all the logistics which have brought us here. And it's a special pleasure because two of my classmates are in the audience here today, the batch of 1967 in CMC Vellore. So I was told that I should take no more than 30 minutes, so I will do that. And what I was told the audience is not hematologists, and therefore I should make it such that anybody could understand what transplant is all about. So this transplant that we're doing is not really a bone marrow transplant. It is a hematopoietic stem cell transplant. So the correct word is to say this is a hematopoietic stem cell transplant. Since it's a tongue twister, we break it down to HSCT. So that's what transplant is about, and that's the cell that we are transplanting. Now this is Donald Thomas, who got the Nobel Prize along with David Murray for his work in stem cell transplantation. And it's not moving. Sorry, I've done something. Okay. So this is Donald Thomas. And in 1960, he and Murray got the Nobel Prize. Murray for his work in renal transplantation. Now this is a person who is George Wesley Santos of the Johns Hopkins School of Medicine. And a person called Goren, who is one of the most famous transplanters, when some students asked him, who is that? They said, that is Santos. And he is one of the few people who've had the privilege of moving the science of hematopoietic stem cell transplant forward. So I think Dr. Krishnadas is one of those who's had the privilege of moving the science of hematology, at least in this state and in this country. So, what is a transplant? Absolute, some basics, okay? So you have this patient here who's got a disease for which there is no other treatment available, right? And you have a matching brother or a sister. So what do? You take that patient, destroy his marrow and his immune system, and then transfer the stem cells from the healthy brother or sister and reconstitute hematopoiesis, and in the process destroy the tumor cells. So that's basically what a hematopoietic stem cell transplant is. Now, in order to do a transplant, we need to have a HLA matching sibling, because tissue compatibility is essential for an allogeneic bone marrow transplant. Now, even that is all changing, so many of the things that I'm saying are going to be different. And this is how, if you have 4 kids, you can have 2 are matched on the HLA loci. This slide should have come earlier. It is another type of transplant called an autologous transplant. Now, suppose you have a patient with a cancer and you have this drug which can destroy the cancer, but in the process it will wipe out the marrow. So what do? Take out the stem cells, freeze them and keep them, give the patient this drug, and then reconstitute hematopoiesis once the drug has been eliminated from the body. And that is the principle of an autologous stem cell transplant. And we do this for lymphomas, we do it for myelomas, and a few other conditions. As I said, what we are transplanting is the hematopoietic stem cell. And what is a stem cell? A stem cell is immortal. I'm 76 now. Will my bone marrow stop working? No. Till I die of a heart attack, it will keep me going. So the hematopoietic stem cell is immortal. Whenever it divides, it puts one cell back into the bank so that the bank never becomes exhausted. It's amazing if you just think of the biology of what makes a stem cell do that, to divide and not allow all the daughter cells to become red cells or platelets. It keeps one back in the bank, right? So unlike the ovary, which stops at 45, this doesn't happen. It goes on till you die of some other cause in general. Now, the hematopoietic stem cell is capable of division, it's capable of differentiation, which means it switches on certain genes, switches off certain genes, and it can become a monocyte like so, a granulocyte, or a platelet, or a red cell, or a lymphocyte, or even an osteoclast. So if a baby is born with osteopetrosis, if you can transplant that baby before the baby becomes blind, the optic canal will remodel. And in order to remodel, you need osteoclasts. And they come from hematopoietic stem cells. So any of these N cells can be treated with a stem cell transplant, whether it is a genetic disorder or whether it's an acquired disorder. So if the bone marrow fails, you can treat the patient with a hematopoietic stem cell transplant. If the immune system is not working, you don't have lymphocytes which are functional, you can reconstitute hematopoiesis. And today, the treatment for a child with SCID is a hematopoietic stem cell transplant. Now, in order to do a transplant, we believed that you had to do something called conditioning. And that conditioning, we thought, were two things. One is creating space in the bone marrow for the new stem cells to come in. And two, destroying the immune system of the recipient so that the cells would not get rejected. Right? Today, we know that creating the space is not so important. Destroying the immune system to allow the donor cells to graft is adequate. Now, we do conditioning either with total body radiation, and George Santos is the guy who showed us that you can do it without radiation and do it with chemotherapy alone. And these are some of the conditioning regimens with various drugs that we use. This is a patient having a total body radiation. In those days, we used to use rice bags to allow uniform distribution of the radiation. Now, this is very difficult in the sense that if you give a little bit too much, you will cook the lung. If you give not enough, you will allow cancer cells to remain. So TBI is a critical component, and fortunately nowadays very few transplants are done with total body irradiation. So what we're transplanting is the stem cell. Now we can get stem cells from the bone marrow, we can get it from the peripheral blood, and we can get it from the umbilical cord. So there are two types, as I told you, allogenic and autologous. If you have a transplant from a twin brother or sister, this is a syngeneic transplant. It's very good because you won't have rejection, but you will not have a component called graft versus leukemia, where the donor's immune system actually destroys any remaining cancer cells in the patient's body. So as I said, you can get it from bone marrow, you can get it from peripheral blood, you can get it from cord blood. This is a bone marrow harvest being done. We take the patient, the donor, make him prone under general anesthesia. Two people work on either side. And I was one of the first who started using sternal needles for aspiration. They are much smaller, so they don't hurt. And the child is running around in the ward in the evening after the harvest has been done. And the bone marrow is collected. Bone marrow will clot within minutes of being taken out of the body. So we anticoagulate it immediately. Somebody keeps count of the cells as they are being collected, and then we send it to the lab to know. Our aim is to give 3 into 10 to the power of 8. So 300 million CD34 cells to the patient in order to ensure that the graft is good. Now you can push stem cells from the bone marrow into the peripheral blood and collect the stem cells by putting the donor onto a machine, a cell separator. These are the older ones, Cobe and Haemonetics. Nowadays it's the Optia, which is a continuous cycle machine. And 3 to 4 hours, you've donated stem cells. So today there are 500,000 Indians who have registered with the HLA registry and are willing to give stem cells if they are called. And most often, we collect the stem cells by peripheral blood stem cell harvesting. So, is there a risk? Whenever a patient asks me, I say, if you walk out of my hospital, is there any chance that you won't be hit by a bus? That's the risk. 1 in a million. And by God's grace, I don't remember a single bone marrow or peripheral blood stem cell donor who's ever had a problem. In a kidney transplant, you're giving up 1 kidney. Here you're giving up nothing because within 2 weeks, the stem cells would have grown back again, right? This is a donor being harvested on the Cobe spectra. Blood is coming out, the stem cells are being collected, and the rest of the blood is being returned to the patient. Now, many imagine a bone marrow transplant being that an orthopedic surgeon will cut open the bone and put the bone marrow in. No, it's actually just a simple blood transfusion. This is a patient receiving the marrow harvested from his elder sibling, and it's just a blood transfusion. So the miracle of transplantation is that hematopoietic stem cells have on their surface molecules. We used to call them mechamolecules, but now we don't want any religious connotation in medicine, so we call them addressins. And like the postman takes the letter and delivers it, these stem cells will find their way to a niche in the bone marrow and actually grow there. So the actual transplant is not done by surgeons, it's done by physicians. It's just a blood transfusion. Okay? So that's the transplant being done for a child with thalassemia. Now all blood and blood products given to the patient after the transplant have to be irradiated. Because even a few lymphocytes in donated blood can cause fatal graft versus host disease. So blood has to be irradiated. So all blood products. Now in the old days, I used to take it to the radiotherapy department, and between 2 CA cervix, my blood would be irradiated to go to the transplant unit. Not anymore. We have blood irradiators. This is the Nordion, made by the Atomic Energy Commission of Canada. It's a beautiful machine. India now has started making cesium pencils. The older one from India was a cobalt 60 unit, which is much heavier and you have to be much more careful about, because cobalt is a highly penetrant radiation. So blood irradiation is absolutely essential. Today, all neonates, all first degree relatives. I was in the US once, and a thoracic surgeon from Kerala called me. And he said, "Sir, I did a coronary artery bypass. It was perfect. Coronaries are fantastic. There's no problem. But the patient has developed fever. His blood counts have crashed. He's got jaundice, and he's got diarrhea." So what was the question I asked him? "Did you transfuse blood from his son?" "Yes, sir." That was fatal. That patient died. Transfusion graft versus host disease. So if you're giving blood for a first degree relative, it has to be irradiated, right? In Japan, where HLA is very similar, they see this much more often than in India. In India, the chance that a donor is haplomatched with you and will cause trouble is much smaller, right? What are the complications of transplant? Number one, the drugs we gave or the radiation. 2, infection. For 2 weeks, you have no white blood cells. So you're a sitting duck for any infection, either from your own gut or from your environment. 3, we put these cells back into a patient and we think they're matching, but they enter the patient and say, "Hey, this is somebody else." And they go to town on the patient. Skin, liver, and intestine bear the brunt of that reaction, which we call graft versus host disease. Now, I've seen only 1 or 2 in my life of grade 4 graft versus host disease. For a child, I still can picture her. You touch her skin, like with pemphigus, it peels off, right? We don't see that nowadays because we are much better at preventing graft versus host disease. Having done all this, the patient can still reject the graft and go back to his primary problem, or he may die of rejection. Next, he can relapse of his leukemia because the donor's immune system hasn't really been able to destroy any remaining leukemic cells in the patient. So these are the complications. We give cyclosporin and methotrexate in order to prevent graft versus host disease. This is again one of my patients in Australia who had grade 4 graft versus host disease and succumbed to the disease. Today we don't see. It's mostly grade 1 or 2, occasionally grade 3. And we give methotrexate and cyclosporin. There are new agents which are used to prevent. This is that patient who I was telling you. And this is a Western skin where they're fair, so the Parma rash is quite characteristic. In Indians, you won't see this because we have too much pigment to make it be seen like that. Now, after a transplant, you are a chimera, which means you are you, but your hematopoiesis is from a donor, right? So I had one mother who told me, after the transplant, this kid is as naughty as the donor. I said, no ma'am, we've only transplanted the stem cells, nothing else, right? So you are a chimera in the true sense of the word, and we use DNA fingerprinting in order to diagnose that there is complete chimerism and all the cells are donor in origin. Some data from the Indian Society of Hematology and of bone marrow transplant. I'm really glad India has a registry. Almost 120 centers report all their transplants to the registry. So we can say as a nation, this is the number of transplants that we're doing. And you can see that this is the transplant activity steadily increasing over the years. This is autologous and allogeneic. You can see that we were doing more allogeneic than autologous, but that's slowly picking up. This is again allo-auto. Allo is blue and auto is red. And this is a new type of transplant. Now suppose I have a patient. He has no sibling who's matched. I have different alternatives, and I'll come to that. One is doing a half-match transplant, and I'll say a few words about that. And this is the transplant activity, the number of transplant centers which do large number. Vellore now does more than 200 transplants a year. In Calcutta, we are doing 100 transplants a year. So the number with a 1.4 billion population, the number of patients who are eligible for a transplant and need it are much larger than the centers available. These are all the different diseases for which we transplant, which I won't go to, but you can see that myeloma is the top one for which we do autologous transplants. After that, it's lymphoma. Among the benign diseases, the largest number are done for thalassemia because we have more than 10,000 children being born each year with transfusion-dependent thalassemia, particularly in the north and west of our country. This is again data from the registries showing the distribution of transplants, indication for autologous, mostly myeloma and next lymphoma. This is allogeneic transplant, different, I won't go into that. This is pediatric transplantation, and this is the trend that is showing that the number of autologous and the number of donor source, which is mud or which is haplo, is increasing. I'll come to that. Now suppose you don't have a brother who's matching. What is your choice? Your choice one is to go for a cord blood transplant. Now an adult 50-year-old cannot be transplanted with a single cord. There aren't enough stem cells. Second is a matched unrelated donor. And there is a registry which I'll come to in a minute. And thirdly is a half-matched donor, right? So almost everybody will have a parent or a sibling who is half-matched. So 90% of patients we can find a half-matched donor, and in India the number of half-matched transplants being done are steadily increasing. Now cord blood, I want to say a word that I do not believe that it is worth harvesting and freezing cord blood, saying that yes, if my other child needs a transplant, I can use that cord. The answer is no. This is a money-making gimmick, and therefore one really should not do autologous cord blood banking. You can give your cord blood to a public cord blood bank, and that's what many people in the US do. And the US has one of the largest cord blood banks in the world, where you can often get a cord for an Indian child from one of those cord blood registries. Now, every country in the world, or most, have a registry of HLA tested donors. And I'm so happy that India has one, and the number is 800,000 donors. We are now collecting cord blood or collecting stem cells from donors in India and sending it to Germany or to US. So that's a really good thing that we are doing, and that's so many people. We had a donor meet in Calcutta where a donor, a young man from Kerala, came to Calcutta to meet his recipient, who was a baby who had a transplant using his cord blood. So that's amazing. My first mud transplant, my second mud transplant, he met his donor in Germany many years after the transplant. So you're allowed to meet your donor 3 years after the transplant. So these are the registries. It's called Bone Marrow Donors Worldwide. And this is the Indian registry with the number of donations. Now, we used to do half-match transplants by taking off all the T cells. We don't do that anymore. It's called a T-cell replete haploidentical transplant, pioneered by Ephraim Fuchs and his team at Johns Hopkins. And I never believed this was possible, but yes, you can do half-match transplants with quite good results. Now, one of the major problems we face in a transplant unit is infection. And the infection is from your own gut. Now, we did a study of stool testing in patients who are going in for transplant. More than 60% have MDRO already in their intestine. And actually, it's not the doctors who are the ones who are responsible. It's animal husbandry. There's no poultry farm which doesn't use polymix. There's no animal husbandry in cows and dairy which does not use antibiotics. And therefore, the food we eat has enough of antibiotic resistance and it colonizes our intestine. When I ask colleagues in the US, do you use meropenem, do you use ceftazidime, avibactam? No, Mammen, we don't. India, if the patient is febrile, and by the third day you know that he probably has Klebsiella, which is MDRO. So it's a problem which we are facing. It's a public health problem. We have to address it. And the newer antibiotics are available, but they are horrendously expensive. And ceftazidime, avibactam with aztreonam is the combination of choice. When I went to Tata, I had the privilege of setting up a new institution there. It was great fun. And this is the hospital. It looks more like a research institute in Scandinavia than a hospital. That is because Mr. Tata was an architect and he was so particular about how everything should look. This is the transplant unit. I had a visitor from US who said, Mammen, we can have lunch off the floor. It looks so clean. So the housekeeping person in Calcutta was called to Bangladesh to teach them how to keep the unit like this in Dhaka. So I was very proud. This lady who had never been abroad was sent to Dhaka to teach them how to keep it clean. It's spotlessly clean. We don't use chemical disinfectants. It's soap and water only. That's a view you can see all around. It's beautiful. It's glass. So if you're in there for 30 days, you're not in jail. And that's the transplant unit. And I'm very proud that the unit in Calcutta is the first FACT accredited unit in India. And this means that our standards and our quality are international. And that is something I'm proud of. I want to close with a story. I think I have 5 minutes more. So the story is about a young kid from Kerala. His name was Anwin Anto. He came to me with skin lesions, recurrent infection, and thrombocytopenia. And Dr. Krishnadas will be happy to know that you can make a diagnosis just by looking at the peripheral smear. They are tiny little platelets, 6 microns, microplatelets, right? That's what he had. So what's the diagnosis? It's a diagnosis of a disease called Wiskott-Aldrich syndrome. Okay? This is a genetic condition. It's sex-linked, so males only are affected. And you have immune deficiency, thrombocytopenia, and recurrent infection, right? So this was not that child's picture, it was a Western kid. And we started doing molecular analysis. So my rule to my PhDs were, you can do what you want, but 30% of your time, you have to do what I tell you to do. So I called Shaji. He's a marine biologist who is from Cochin, who is now reviewing articles for British Journal of Hematology, right? If I have a question in thalassemia, I'll call him. Okay? So you must, respect the scientists who work as your team. And they must be equivalent. So I'm so happy that a professor of lab science will get the same as professor of cardiology in CMC Vellore. So I called him, I said, Shaji, I want molecular diagnosis. So he said, no problem, sir, give me a month. And within 1 month, it's a huge gene. We had done the molecular analysis, and we had a paper at ASH, which I haven't shown you, but we were able to say that in our population, these are the mutations which cause viscodilage. So many of you will ask, so what? Yes, one paper. And today science is not only papers, it's something which does good for humanity. So this Anwin's mom came to me a few years later with this. I think there are obstetricians in the audience, so they will diagnose it straight away. It's a twin pregnancy. Okay? There are 2 fetuses. So what do? We put a needle into each placenta. One placenta, baby is female, we don't proceed further. This disease does not affect. Second was a male. So we did the WS mutations, and we told the father, this child is affected with viscodilage. So we have to inject potassium chloride into the heart of the affected male. The fetus will be blighted. Now the father was a Roman Catholic. He said, Dr. Mammen, how can you do that? I said, I did the testing only because you were willing for an abortion if the child was affected. What a great hematologist I am. Now the father is telling me, can't you see whether they are matching? We did the HLA typing. The female baby was matched HLA with the affected male baby. Right? So at the time of delivery, we collected cord blood. 3 months later, we called the baby back and we did a transplant using the cord blood of the female twin. Right? And this is the baby just before being discharged with mom, another one with mom. And this is a picture which I always prize, sent to me by the father. So the boy on the extreme, my side, is Anwin. Father didn't give up. He found an uncle who was matching. We transplanted Anwin. And that's the twins. The little girl is the one who gave her cord blood for the boy. And you can see what modern medicine and modern science can do for one individual family. So as David Nathan, the pediatric hematologist, said, the new millennium is a remarkable time for medicine, where the potential for bettering human health is unequaled in history. The ongoing revolution in biomedical science of unprecedented magnitude is accelerating dramatically and promises almost unlimited opportunity for the betterment of humankind. These are my colleagues at CMC and TMC. I thank them, my research associates, my registrars, nurses, and patients and their families for the trust they put in us when they subject one child to a transplant. Thank you very much.
Thank you. Thank you very much, Dr. Mammen Chandy, for your explicit exposition of a subject of which we were very leery in the beginning. I still remember when I was working with Dr. Krishnadas,
I was also interested in hematology. But bone marrow transplantation was a dream, although it was done by Donald in 1956. But the first transplant, as you know, it is from Advani, from Tata Memorial Hospital in 1983. I remember him because his wife is from Kerala. She's still there. And your transplantation in 1986 was a great news to us because we didn't know that it could be done. And now you are telling this as it is like a blood transfusion. And I'm sure that I don't want to prolong further. 26,000 bone marrow transplants were being done in India from 1983 to 2022. And about 1/3 were autologous, the remaining were allogenic. But as Dr. Mammen said, now we can do bone marrow transplantation in half-matched donors, that is, haploid transplantation, even if it is not matching. And about 35% of the allogenic transplantation now is haploid transplantation, which means a stimulus, gives a stimulus to us, so that further and further we don't have to worry about these things. We'll have more donors. We have, as Dr. Mammen said, we have only 500,000 stem cell donors now, where globally there is 40 million. And now we will have more donors because it is more specific, low cost, awareness of the patient, accessibility, and more centers available so that bone marrow transplantation or as a stem cell transplantation will be a very favorable tool in treatment of not only leukemias but also diseases like aplastic anemia, thalassemia, so many other diseases, lymphomas, things like that. So with these short words, I thank you very much for your exposition and for making us understand that there is nothing to worry much about the transplantation. And we hope more centers will be opened up in our country about this stem cell transplantation. Thank you very much.
Trivandrum Medical College Alumni Association, Professor V.C. Matthew Roy Academy and Krishnadas and Kamalam Foundation. This certificate is proudly presented to Padmashri Professor Mammen Chandy for delivering the Professor K.V. Krishnadas Oration on the topic Bone Marrow Transplantation, the Basics, held on 17 September 2025 at Government Medical College, Trivandrum, signed by Dr. C. John Panikar, President, TMCA, Dr. Matthew Thomas, Chairman, Krishnadas and Kamalam Foundation, Dr. K.R. Vinay Kumar, Chairman, V.C. Matthew Roy Academy.
Dear friends, the oration is over, and we thought the committee, alumni committee, and the trust committee thought that we should have a panel discussion to have some practical know-how or practical future for the oration. So we are planning a panel discussion on bone marrow transplantation, and I'd like to call the following experts to come to the dais. Dr. Ashwin from KIMS Health is a hematology consultant. Dr. Lakshman, again from KIMS. Now, Dr. George Abraham, Assistant Professor from Regional Cancer Center. Dr. George Abraham. Dr. Shankar from Pediatrics, Dr. Shankar. Dr. Srinath, I don't know whether he is there. He was not well. Can I call instead? There are two people who have not come. Can I call Dr. Nikhil? Oh, no. Dr. Nikhil, you can join because two of our people are absent. I ask the audience to be seated, and we will have a very short panel discussion, and each of the panelists will answer a few questions, and each of them in a very short time of 5 to 6 or 7 minutes. Please be seated. We will start the panel session, and the first question is just we want to have a bone marrow easily done in the city of Trivandrum. So that is what the basis of the panel discussion. So the first question, what are the fundamental infrastructure requirements needed to establish a BMT program in Trivandrum, and what are the minimum standards we must meet? This will be answered by Dr. Ashwin in a very few words about just the points for about 5 minutes.
Before starting, let me thank Trivandrum Medical College Alumni Association and Krishnadas and Kamalam Foundation for inviting us as a panelist here. So, setting up a BMT unit in a hospital, so usually this is possible in a tertiary care center because hematopoietic stem cell transplant obviously is the teamwork. So, before planning the infrastructure of BMT, it is a good practice that you can walk around to the other departments, meet your blood bank physician, because you have to ask, because blood bank basically requires license for every single procedure they are doing. They need a stem cell apheresis license, they need a granulocyte apheresis license. So you can meet them, you can ask like what all facilities are currently available, whether we have a stem cell apheresis license, we have the facility to do it. Do we have facilities of irradiation? Because as Mammen sir has already told, these are like minimum requirements we need before planning for a BMT unit. Obviously, we need to know whether our center does a CD34 enumeration. Then we can walk around to our microbiology department. We can ask them, because like what sir has told, infection is one of the most dreaded complications. So we need to know like what all facilities we have. We have to look into the infection control team of the hospital. Then when coming to the infrastructure as such, so we can face like two situations. One is we are going to a tertiary center which is already established, where we have to look into where we will set up the BMT unit. Second is someone is calling us, okay, we are building a new block and we need to set up a BMT unit. So we select a place which is like far from any infectious wards, any construction sites. So preferably if we have an option to get the top floor of a building, then that's the best. So most of the time what happens is we end up landing in an existing facility, so we have to look where we can set up the BMT unit. So like what sir has shown, the BMT unit, the main thing we have to do is it should be in a facility, in a site which is not near any infectious ward or anything. We have to set up in such a way that we have to discussion with the architects, the engineers and everyone, how we plan to set up a BMT unit. So there are certain standard guidelines available to set up the BMT units. Basically, we go from like an area, everyone can enter inside, then comes the restricted zone, then it is like the strictly aseptic zone where the patients will be there. So we can set up a BMT unit with 2 beds to begin with. So imagine a room, so we have the room here, it should be well lighted. So you have seen like good windows in that particular picture. It is very important because once the transplant patient, especially the allogenic transplant patients, are into the room, the patient and the bystander are going to spend nearly a month in the room, maybe more. So it has to be a well lighted room, otherwise like everyone will feel like depressed after some time. So one is that lighting, then the room should have a HEPA filter, definitely. So for autologous transplant, you can proceed even without a HEPA filter, but for allogenic, it is preferable to have a HEPA filtered room. There should be a positive pressure ventilation. There should be a pressure difference between the patient's room and the hallway so that the air will not enter from the hallway to the patient's room. All these are mainly to prevent infections, especially fungal infections. The room should be very clean. There should be like minimum things inside the room. Then preferably the patients, we can have the doors in such a way that like it opens and closes automatically with some sensor. Because if you see what ID people say is the maximum infection spread from the handle door. So these are the minimum requisites you need inside the room. Then you will have a nursing station outside. So usually it will be like a 1-to-1 ratio of nurse to the patient. You have separate dirty utility room and all outside. We usually have like minimum visits unless it is essential. We do the visits. Usually the clinical round starts first from the BMT unit. So like we come fresh and we start the rounds from the BMT unit. There will be specific areas for hand wash and all. It will be just like a ICU setup. There are certain guidelines like you need this much of air flows, like 10 air flows every hour. These HEPA filters need to be changed every 6 months and so on. So to conclude, like we can just start with like a 2-bedded transplant unit, and as the volume increases, we can add upon the other facilities.
Thank you, Lakshman. Now, Ashwin will tell us something about what are the ad, ad, cooperative departments what we should have in a bone marrow transplant.
So, when it comes to the various staff and departments in the BMT unit, so basically the most important staff for a BMT unit is their nursing staff. So you need very good trained, dedicated nurses, and a success of a BMT unit is usually dictated by how good their nurses are, and it's important to keep the core team of nurses, together for a long period of time, and to avoid attrition, especially in terms of nurses. So definitely the heart and core of a BMT unit is the nursing team over there. Along with that, like Sir said, the cleaning staff, there'll be a lot of other, para-service people who are very important for the BMT unit to run along in an efficient and in a mechanical way. As far as the doctors are concerned, usually it's an hemato-oncologist or an oncologist who leads the BMT unit. Ideally, you would want more than one of them to share the stress, share the work and all those things. After that, as now we are becoming more and more specialized and compartmentalized, definitely you need a good critical care support to help with your patients when they become more and more sick. But I think especially in the past decade and all, it was usually the hematologist only who used to manage everything at their own level. But now, if you can get a good critical care support, it always helps your cause. And then the most important people are the ID people, the infectious disease people. So hematologists have to be good at infectious disease, but still, it's always good to have an infectious disease specialist along with you who can help and guide you in very difficult situations. So nursing staff, the cleaning staff, they are the heart of the BMT. Then the hemato-oncologist, along with their ID physicians and critical care physicians, would be the doctors in the BMT. As far as the BMT program is concerned, the most important people are the BMT coordinators. So you need to have one or two good BMT coordinators who can help coordinating with the various patient requirements and all those things, because patients are always worried, they're always stressed, they're always tensed. So it's important that there is always one person or one line of contact for them, which is not a doctor, to whom they can frequently contact, solve their small issues and small problems. So a BMT coordinator, a social worker, these people are actually quite core to a good BMT unit, Obviously, other than that, now social worker is there, BMT coordinator is there. Then obviously transfusion medicine, like Dr. Lakshman said, transfusion medicine is a very important part of our BMT program, right from the apheresis up till blood transfusions and all other things, providing granulocytes when the patients become neutropenic and all. So having a good transfusion medicine team, having a good apheresis team which provides you products 24/7 round the clock is also very important for a successful BMT unit to run along. Okay, so to conclude, this is the core that you need to have a good BMT unit. These few peoples are very important.
Thank you, Dr. Ashwin. Now we'll go to Dr. George Abraham, who is the assistant professor in medical oncology, RCC Trivandrum. You can continue with the supporting departments and the collaborations you can.
Yeah. With regard to the same question, I think Dr. Ashwin has highlighted most of all the important requirements for a BMT unit. With regard to the staff, the qualities which they have, in that perspective, if I look into it, the staff in BMT, which as Dr. Ashwin has mentioned as the core component of the BMT program, should be equipped or should have an experience in managing sick patients. The most important component of a BMT program, especially in an allogenic transplant, is the unpredictability of when a patient gets sick. That is, you cannot calculate that this patient is going to get sick at this day. It just happens out of a blue moon when we expect things to be going all normal. Suddenly the patient, some unexpected thing happens, especially in allogenic transplant. So the staff should be capable of or experienced in managing a critical care, critical illness. That experience is very crucial. So whenever staff postings are allotted, we usually allot a senior nurse and a junior nurse. Two junior nurses are never allotted to a BMT unit for the night. So that is one crucial thing. In picking up sick patients at the earliest is a crucial component, is very important. The other important and the major devil is infections. So at each point, whenever a person walks in, at each point there are certain infection control precautions. At this point you have to scrub in, at this point you have to do multiple sets of hand washing. Each component is very crucial, and that strict adherence to infection control measures is very crucial for a successful BMT program, and that has to be reinforced. I think periodic quality checks and reinforcements is essential to maintain that. It is not just to teach them once, but that has to be reinforced over a period of time to maintain good infection control practices. Then the other requirements, like there should be a specialized person who is trained for doing FRSs and FRSs procedures. There should be person who is able to do cryopreservation, DMSO cryopreservation for stem cell preservation. That has to be specialized. And most importantly, the staff in BMT should have good communication skills, so that the patient, as they spend a time of 1 month in a closed room, many of them get that mental fatigue. So good communication skill, not only with the patient but also with the bystanders, is something which is very essential, which I felt was necessary in BMT settings.
Thank you. Now we come to the important question of funding and financial sustainability. Dr. Nikhil, who has got much experience, will tell us something about the funding, how they can sustain, and where are the sources of funds and everything.
Thank you, sir, for this opportunity. It's an honor to be in this panel, especially Oration in my grandfather's name. First of all, regarding funding, a lot of the templates are taken from Mammen, sir. I'm the oncologist who work with my hematologist, both who have trained me. They indirectly, Mammen, sir, is my, he is the one who has trained me in bone marrow indirectly. One thing is the majority of the patients are not self-funded. I think in our setting right now, 30% people pay out of their pocket. Most of them depend on the crowdfunding. As Dr. Lakshman and Ashwin mentioned, there's a very important role for the social worker. As soon as the patient comes, we feel indication about allogenic transplant is there. We do counsel them of the financial liability. I always keep up a backup amount for the the morbidity we expect with the transplant. There is a lot of crowdsourcing going on. A lot of patients are dependent on the insurance. For example, we have the central government insurance from the mines, collieries. For a lot of the benign transplant, because we have very good outcomes and long-term survival and make them useful members contributing to the society, there is government funds which we can tap into. It takes a lot of work, and sometimes it feels stressful. Most of the times clinicians are along with the other people doing it, but there is a lot of funds to tap into from central government for a lot of benign disease. For malignant, we don't get as much, but we do depend a lot on crowdfunding. You do a lot of work, set up a proper documented letter, what could be the possible expenses, give it to Panchayat. At least 50 to 60% of the expenses can be met by crowdfunding. And that's an important source, because only 30-40% of patients are self-paying in the current scenario that we have. We see up to around 70 transplants, with 70% of them being allogenic. So these are the sources that we look into at the moment.
Thank you, Nikhil, for telling us the way to find funds for these patients who run into lakhs, and that is one of several sources he has said. Finally, Shankar, could you tell us something about how can we establish an effective inter-institutional cooperation and create a sustainable Trivandrum BMT group that benefits all stakeholders.
At the outset, I thank sir for giving me the opportunity. So I am not a person who are doing bone marrow transplant in our center or in our place, but I am basically a end user actually, because when a patient, as a pediatrician or a geneticist, when patient comes, we diagnose, we need bone marrow transplant, but we are not doing it. We are actually using the other centers. Especially in my early part of career from 2007 to 2018, I am basically using only CMC Vellore as the center, where sir was there, Alok sir was there, Biju George, Vikram, Matthews, Fauzia. So we had a very good rapport with them. Actually, I will counsel the patient. I will take half an hour to 1 hour telling regarding the entire process of bone marrow transplant. I will refer to Fauzia or Vikram Matthews or Biju George, and they will reply to me. So we had a good rapport, and we were able to convince the patient regarding the importance of bone marrow transplantation. Since we are, as Nikhil told, most of the patients which I used to deal with, the non-oncological patients like thalassemia, osteopetrosis, primary immunodeficiency disorders, Viscoat-Aldrich syndrome, SCID, and all these patients have excellent response to bone marrow transplant. And we have done more than around 25 patients in last 10 years, if you say. And now we are not having a single young patient of thalassemia on transfusion. For last 10 years, all thalassemia patients we diagnose, we will do the transplant by counseling as well as the help of the other centers. So if you take the funding also, Kerala government is also having a Arogyagiranam scheme as well as for the KSSM scheme, through which we are getting up to 20 lakhs of fund for children. Less than 18 years we will get it. And now I am heading the help of the nodal officer of the rare disease program. Rare disease group 1 diseases, where is thalassemia, Fanconi anemia, immunodeficiency disorders, storage disorders like mucopolysaccharidosis, X-linked adrenoleukodystrophy, all the storage disorders, we will be able to give up to 50 lakhs for the transplant program. So I think fund is not an issue, collaboration is not an issue. Only thing is centers has to do that. And from this March onwards, in the rare disease program, we have expressed the interest of the private sectors also to get into that. Now we are mainly concentrating on the Malabar Cancer Center, where Dr. Chandran is doing a transplant program. And last 1 year we have got around 4 patients we have done. Already 2 patients are under follow-up, 1 CGD is under care of. So I think with better counseling, awareness among the clinicians, and by proper counseling and linked with the transplant center, we can do, even if centers are few, we can do wonders in the transplant program. And so many diseases we can do transplant. So in Trivandrum also, if wherever centers they are doing it, if primary clinicians are interested, if we found a group of among the interested persons, we can do the clinical collaborations, we can do research collaborations, we can do awareness collaborations. All those things can be done in a regular basis, so that even though interested people are there, like-minded people are there, we can do wonders with this bone marrow transplantation or hematopoietic stem cell transplantation and help the people a lot.
Thank you, Shankar. I think you should take the lead for this. So I think the panel will give you the lead to make such a consortium where all the people can join together. Dr. Mammen, you can tell the rest what all they have missed out.
I don't think they have missed too much, but I think I'll start with the last person who spoke and say that sometimes transplant is only the beginning of the journey. And having a good pediatrician whom I can talk to post-transplant for a child whom I have transplanted is a wonderful thing. Because the father calls you saying child is having high fever. You want a person who understands that this child is immunosuppressed, who will look after, who will talk to you and say, okay, this is how you're going to do it. So, because the child needs to continue chelation, if there was hepatitis B, we need to look after that. Growth is an issue, reaching puberty is an issue, counseling regarding fertility is an issue. So all those things have to be done in liaison with the referring physician. And I often find that if the patient has been seen by a good pediatrician, physician, and then referred, they've already been primed. They understand. And it's easier for us to talk to them.
Thank you for those words, and I think we will take your help also for all these things. So thank you very much. We have some online comments. Dr. M.V. Pilla sir, are you there? Can you tell some comments if you are hearing our panel discussion regarding formation of a good bone marrow transplantation consortium in Trivandrum? Dr. M.V. Pilla sir, Dr. Shafiq from UK. Dr. Shafiq, are you there? Yes. While we are searching, any of the audience have any comments and suggestions?
I am Dr. Thomas Titus, cardiologist. I want to ask two questions. One is why is it that we don't see so many graft versus host rejections in spite of transfusions right and left? And the second question is whether in DiGeorgi syndrome, whether we have to always give irradiated blood.
So the first question was, as I said, in certain populations where HLA, like to get a donor in Japan is very easy because the number of HLA haplotypes in the population is few. Therefore, the chance that a random blood donor, now suppose I give blood for my son, I will be half matched with him. And therefore, there's a chance that my lymphocytes will not be detected by his immune system and can cause GVH. Okay? So one first degree relatives, no. In fact, I recognized the first transfusion graft versus host disease only after I came back from Australia with transplant training. Most of it will get missed as Steven Johnson syndrome, counts have fallen, Septran was given, he's got jaundice, and nobody will ever diagnose transfusion GVHD before the patient dies. Okay? So all I would say is that it's rare in populations like India where we are so heterogeneous in our HLA types, and therefore in populations where there is commonality of HLA inheritance, your chances are high. In cardiac surgeons in Japan were the first to report, they called it post-transfusion erythroderma. That's what they called it. And it was mild graft versus host in Japan. So we didn't, it was the thoracic surgeons who first detected post-transfusion erythroderma. That's what they called it. Right?
I think that must be a case of DiGeorgi syndrome. Thymic hypoplasia with aortic arch abnormality. They are prone to this.
Second question is, if a child is immune deficient, see, this is why now I'm working in a corporate hospital which doesn't have a blood irradiator. Okay? So if a neonate requires a transfusion, as per AAAB guidelines, it has to be irradiated. Right? So how to irradiate? I have to send the blood to Chennai even though CMC is close by. But I feel this is where shared resources are important. No center which has a blood irradiator should deny irradiation of blood for any other hospital, be it corporate or private or government, in that region. Because the source is decaying, whether you put in a unit or not. It doesn't cost you anything to irradiate the extra blood. So answer is one, in Indian population, post-transfusion GVHD is rare, particularly if you are immunocompetent. If you are not immunocompetent, the risks are very, very high. Hodgkin's disease. Suppose you are taking up a patient with Hodgkin's in the mediastinum for a biopsy. Nowadays the radiologists do it, so it's not a problem. But if the patient comes with a HB of 6 and you're transfusing, you irradiate the blood. Because Hodgkin's is very, very immunosuppressive. And it's a common disease. I lost my first Hodgkin's because a patient went to Dubai. Last cycle of chemotherapy, hemoglobin came down. They transfused 1 unit of blood. She came to me with jaundice, diarrhea, with cytopenia, and died. And she was the relative of one justice of the High Court. So I thought I'll be sued, but fortunately they couldn't sue the hospital in Dubai. So we need to be aware of it. In a survey done in the US on the awareness of transfusion GVHD, less than 10% of practicing physicians and pediatricians were aware of transfusion GVHD.
Thank you. I think there is Dr. Ram from Canada. Can you throw in some few comments, Ram? You're online.
Yes, can you hear me?
Yes, little more loud.
Thank you so much for inviting me, and it was an excellent oration by Dr. Chandy, an excellent discussion here. I work abroad, like Dr. Chandy said, our antibiotic policies are very relatively easier to follow. But when I worked back in India and in Chandigarh, we had this problem that Dr. Chandy said about the antibiotics and how infection used to be a big problem, and we needed to keep increasing the strength and intensity of antibiotics every 3 days. What would be a practical solution for this problem, especially in the light of increasing transplants across the country? Like, how are we going to address this? Because we can't keep inventing new antibiotics and or like those escalating this. So my question is directed to Dr. Chandy for his all his experience and expertise about how does he think that we can tackle the antibiotic problem?
Number one, we need policies of antibiotic stewardship, which means that nowadays, fortunately, more and more ID physicians are available in tertiary care centers, and they actually control antibiotic policy, which is a good thing. And the second is in the community. See, you can walk up to a pharmacy and say, "Thonda vedana unda, pani unda," and he'll give you an antibiotic over the counter. So that we probably have to discourage. And thirdly, I think the Ministry of Agriculture has to seriously look in, because it's linked to profit and productivity. If you don't give the polymyxin to the cows, your yield comes down, you have a problem. So it's a very sensitive issue which one has to tackle, because actually I think it's not the clinical use of antibiotics which is responsible for the problem as the use in agriculture and animal husbandry.
Thank you. I think, Dr. Ram, you got the answer. So this problem you may not have in your place, that we are still facing. Anymore, if there are no, we will just conclude the panel discussion. We thank all the persons who have chaired and all the participants. And what are the, yes, one more. Yes, Panika.
My name is Panika. I am not a doctor. My question is to Dr. Chandy. Sir, I thought you said during your oration that cord blood cannot be given to a sibling, but that it can be given to somebody who is unrelated. Would you, at least that's what I understood. Could you kindly expand on that?
I need to explain. I'm sorry. Matthew told me strictly 30 minutes, so I was very careful about time. So the question that is being asked is cord blood banking. Okay? In India now, if you go to any hospital, there'll be a nice board with life cell or stem cell or whatever, and obstetricians are making 20,000 rupees a day just by, instead of throwing the placenta in the bucket, they are sending it to one of these centers. They get 5,000 rupees for doing it, and the patient pays every year. And when you have Aishwarya Rai on the front page of Times of India pointing at you saying, save your baby's cord blood, it's insurance for the future. How will any mother not want to save the cord blood? So it's a business, right? Now that is private cord blood banking, where you collect blood in case you have a child who has a problem. Now, is it a good thing? I gave you one beautiful example. One baby has got Viscott-Aldrich syndrome. They're going to have another baby. Definitely, you collect cord blood. If it's HLA matched, you'll do a transplant. You have one child with thalassemia. You're planning your next baby. You don't have the money for a designer baby. In which case, in case that child is not thalassemic and is HLA matching, you will use that cord blood for a transplant. No problem. Okay? So in selected, but saying that this is insurance for any child, if a child has leukemia, the cord blood from a sibling is of no use because there will not be graft versus leukemia. Okay? So public cord blood banking in the US, where any woman just signs on a paper, her placenta is taken. I visited the largest cord blood bank in University of Washington, Cardinal Glennon Bank, and the amazing work they're doing with public cord blood banking. And I can access a cord blood unit which is stored in the US. Okay? So yes, we must encourage and have public cord blood banking, but private cord blood banking where you do not have a child who already has a disease which needs a transplant, the chance that you will use it, one, is very, very rare. The chance that it will work because it's cord and the immune cells have not yet developed is less, so relapse is more.
Thank you so much.
Yes, thank you,
and we
Doctor.
have come to the end of the panel discussion. And the fruits that we have gained out of the panel discussion, I would say that the interaction between different groups in Trivandrum, and we have given the charge to Dr. Shankar to promote that, and we have discussed that any amount of money can be got, but how in a proper manner, that should be really thought about. And I strongly request, the second fruit that we heard was the antibiotic use. The Alumni Association and under probably through the government should be given a beautiful letter should be given. The antibiotic resistance is partly due to the animals being fed on heavy antibiotics and antifungals. So if this takes a turn, I think it will be beneficial for all the Indians who has an infection and who has to take antibiotics. So I think these are the two things that we have learned or come out, and I thank each one of them, and I thank the chairpersons for conducting this, and we will come to the end, and thank you for the Alumni Association to include this panel discussion. So many people have heard what's a panel discussion about bone marrow transplantation. It's not the continuation of what Dr. Mammen has said, but to have somebody who is eligible for transplantation in Trivandrum, to have the transplantation in Trivandrum itself with all these suggestions. Thank you very much. Huh? Yes. Yes, we do. Yes.
Thank you, sir.
Both RCC
I'm-
and KIMS has got a dedicated blood irradiator. Otherwise, we used to give irradiated in the external radiotherapy machine also.
Thank you, sir. I am Dr. Lakshmi. I am treasurer of Trivandrum Medical College Association, Alumni Association. On behalf of Trivandrum Medical College Alumni Association, I thank all my respected teachers, and my colleagues and all the panels who have participated in this panel discussion, as well as the oration, which is based on my respected teacher, Dr. K.V. Krishnadas sir. I remember 30 years back when I entered this college, and in the final year, I was a little bit frightened to see the Davidson as well as Harrison textbook of medicine. But then I saw the K.V. Krishnadas sir textbook, and it's so easy for youngsters to read and learn. And I still remember with respect how sir has presented in the textbook. Thank you all my esteemed teachers, colleagues, and dear friends for attending this oration as well as panel discussion. Thank you. All of you, please join for the dinner outside.
കുഴപ്പമില്ല